Okay, so today we are going to talk about the respiratory system. This is going to be broken down into a couple different chapters just to make sure to get all the information in so you can look at the different learning outcomes for each of the chapters. Respiratory is going to be a large part of our exam number 2 because we will have a lot of patients in nursing that will have respiratory problems. So this is going to be a very common lecture to make sure that you understand. Okay, so first we're going to go ahead and go through a little bit of the anatomy and physiology of the respiratory tract. We are going to split it up into the upper respiratory tract and the lower respiratory tract. So the upper respiratory tract is mainly responsible for bringing air into the body, helping to kind of filter it, clean out some of the debris that might be in the air, warm it, and humidify it before it reaches the lungs. Now, there are some structures here for the upper respiratory tract. This is going to be the nasal cavity, the nasopharynx, the oral pharynx. These two areas are kind of that back area of the nose and the mouth, down into the larynx. This is where our voice box is at, and then down into that tracheal area. Again, we do a lot of filtering out pollution, things like dust and pollen and different types of microorganisms through the use of mucus. So our respiratory tract has a lot of mucus in it, and cilia, which are little tiny hairs. So these help to make sure the lungs are not damaged by any type of debris or things in the outside air that might cause us to get sick. In our nose, there are actually like turbine shaped little filter areas inside that nasal cavity that help to move the air, which helps to humidify it and warm it up. So that's going to be important to understand when we are giving patients supplemental oxygen, is that we want to make sure to warm the air and humidify it. It also helps to provide sense of smell so that we can get sensory input into our nervous system. It helps protect our lower airway through the movement of the epiglottis, and it helps produce speech through the movement of our vocal cords. So we will talk about dysfunctions of the upper respiratory tract, and we'll kind of look at those types of problems throughout this lecture. For the lower respiratory tract, we have the trachea, so that's right down in the middle there. That bifurcates off into the bronchus or the bronchi, and we have our left and right side, and then it branches down or goes down into the bronchioles, which split off into the alveolar ducts and ultimately end at those alveoli. So the most deepest part of our lungs have alveoli, which we'll talk about, but that is where the carbon dioxide and oxygen gas exchange occurs. So the lower respiratory tract is mainly responsible for bringing air into the lungs and then ensuring that that gas exchange occurs so that we can get rid of carbon dioxide and bring in oxygen, since that's what our cells use, is oxygen. So there are a couple different supporting structures to note. There is the diaphragm, so that's that big muscle underneath our lungs. This is what contracts and helps with inhalation and breathing in, and then it relaxes, and that's how exhalation occurs. We do have our pleura, so this is a lining of the lungs. The pleura helps to protect the lungs itself and helps to create an environment where we have enough pressure on the lungs to be able to maintain inflation of the lungs. So we'll talk about the pleural space as well. Then we have our intercostals. So these are the muscles that are in between our ribs. So inter means in between, costals meaning ribs. And this helps with breathing and the movement of our chest wall. So Sometimes we're going to see these supporting structures being involved when we're talking about disorders of the upper and respiratory tract as well. With the common disorders of the lower respiratory tract, we're gonna look at disorders that will primarily occur when there is damage to the alveoli, the lung tissue itself, or a problem with ventilation, meaning breathing in, breathing out, and perfusion, which is the blood movement that helps with CO2 oxygen exchange. So we're going to talk about those on the next couple slides as well. Okay, so we're going to talk about a couple different concepts here on this slide. We are going to talk about ventilation, diffusion, and perfusion. So these are three concepts that are pretty heavily tested on as far as NCLEX goes. And we aren't going to go to the cellular level here on this, but we're going to need to understand how ventilation, diffusion, and perfusion impact different disease processes and what we're going to see in our patients when these three items are impacted or have a dysfunction with it. So we'll start with ventilation. So ventilation is actually the air moving itself. So when we look at oxygen delivery, when we look at breathing, it's actually a three-step process. So first we have to have ventilation, which is the moving of the air itself into and out of the lungs. So again, that air travels from the nose down through the pharynx, into the larynx, into the trachea, down through that bronchi and bronchioles, into the alveoli. When we ventilate, we take oxygen from the outside air, we inhale it into our body, down into that tract, into the alveoli, and then we do an exchange to where carbon dioxide is then exhaled and given out of the body. So we don't want to retain carbon dioxide because that becomes acidotic or an acid in our body and can create an environment that is not good for our tissues in our body. So normal ventilation will always require a patient to have an open airway. So that's why when we're talking about respiratory disorders, you want to look at, does the patient have an airway? So it's the A. Then we look at the actual functioning of the lungs. Do they have healthy lung tissue? Do they have functional respiratory muscles like that diaphragm working correctly? And then do we have correct nervous system stimulation like that intact brain area of the intact respiratory area of the brain? Most of our problems when we're looking at an abnormal ventilation has to do with either the airway itself, so things like an airway obstruction or a narrowing of the airway, or some sort of problem that stops the respiratory muscles from moving or the respiratory function in the brain from occurring. So those would be things like medication overdose or neuromuscular disorders, okay? Then we have our second part of oxygen delivery, which is diffusion. So diffusion is actually movement of gases. So this is that movement of oxygen to transfer into carbon dioxide and move across the alveolar capillary membrane. So those alveoli that are deep down in our lung tissue, these look like a bunch of grapes. So you'll oftentimes see pictures of them and they look like little balls of grapes. Those alveoli have a lot of surface area on them. So the alveoli will actually, if you stretched out the amount of alveoli that we had and you laid it out flat, it would actually cover about 2 to 3 tennis courts of flooring. So we have a lot of surface area there, and that's good because we have the diffusion or movement of gases, that exchange of oxygen and carbon dioxide through that alveolar capillary membrane. This movement does occur because those gases move from an area of higher concentration to an area of lower concentration. So the oxygen inside the alveoli has a high level of oxygen that will move across the alveolar membrane into the pulmonary capillaries and then move into those red blood cells. The blood cells then will switch out the carbon dioxide, which is a byproduct of our body using up the oxygen, and that moves across the membrane from the blood into the alveoli and then is moved back out when we exhale. So from the alveoli to the bronchioles to the bronchi and then backwards. So it's that process of that ventilation in a backwards way. So normal diffusion typically will require our alveolar membranes to be intact, to be thin and flexible, to have that large surface area, and make sure that we have an adequate amount of oxygen coming into the body. So when we're looking at diseases that affect diffusion itself, would be things that would damage those alveoli or the alveolar membranes itself. So those would be things like pneumonia, pulmonary fibrosis, ARDS, emphysema. So those kinds of things that will actually damage the alveoli or make them to where they're not moving and able to move the blood across the membrane. So that CO2 and oxygen exchange. For our third part of respirations, we have perfusion. So in order to have good oxygen delivery, we need to have perfusion. This is where we will have the blood flow itself going through the pulmonary capillaries, which surround the alveoli. So those alveoli, the bunch of grapes, has capillaries surrounding, kind of in a meshwork layering, that help to bring blood to the alveoli, which brings in the blood that is low in oxygen and high in carbon dioxide, and then will help take out the blood into the body that is high in oxygen and low in carbon dioxide. So the pulmonary capillaries really help with perfusion. Now, in order to have normal perfusion, we have to have normal blood flow. So that would mean we would have to have a normal cardiac output, normal healthy heart movement, electrical impulses. Those pulmonary arteries have to be open to allow the blood to flow and have good circulation. So some things that we see, disorders that we're going to talk about that would impact normal perfusion or blood flow would be things like a pulmonary embolism, which is a blood clot in the lungs, heart failure, so that's the heart not effectively pumping correctly, shock, which is a lack of blood or bleeding out, things like that, or severe hypotension, which is a lack of blood pressure itself. So once we put everything together, those three steps, then we would have our correct ventilation, diffusion, and perfusion to be able to bring oxygen to the tissues and carbon dioxide out of the body. Now, when we look at a VQ mismatch, what we're talking about is where the air reaches the alveoli, which is our ventilation, and blood reaches the alveoli through the perfusion and those capillaries, the gas exchange would be enough. A VQ mismatch, ventilation meaning V, Q is for perfusion. This mismatch occurs when the ventilation and perfusion are not adequately matched enough. So sometimes we can have air not coming into the alveoli, but blood flow is normal. And then on the other hand, sometimes we can have air coming into the alveoli, but that blood flow is reduced or absent. So that would be a perfusion problem, vice versa, a ventilation problem. So sometimes we can see issues where we have normal diffusion, but not normal perfusion, and vice versa, normal perfusion, not normal ventilation as well. So we'll see that with a VQ mismatch. All right, so we're going to start off with our patient here. Now that we understand a little bit about the respiratory system, how it works, we're going to move into the assessment aspect of the nursing process, looking at our patient here. So when we get a normal patient or a patient coming into our unit, we will want to start with an assessment, a respiratory assessment. This is going to give us an idea of how that patient is oxygenating, if they are ventilating appropriately, and if they have good circulatory findings related to the respiratory system as well. So when we look at a respiratory assessment, we are going to start with positioning. So that's important. We want to make sure that the patient is either sitting upright on the edge of the bed or we've raised the head of the bed. This way we can get a good idea of their optimal breathing pattern. Okay, we don't want to assess their breathing if they're slumped over or they're not, if they're supine or I'm sorry, prone, if they are, hunched over, doing a tripod positioning, anything like that, because those lungs are not expanding sufficiently enough. And so we might get some abnormal findings that maybe aren't really there. So first thing is position, and then inspect. We're going to look first. We're going to look at their posture. We're going to look at, do they have any rapid breathing, any tachypnea? Do they have any bradypnea or decreased breathing rate? We're going to look at accessory muscles. So do we see their intercostal space moving in and out? Is their diaphragm going up and down correctly? Do they have any abnormalities with one side of their chest rising and falling when they breathe, or is it symmetrical? Then what we're going to do is we're going to palpate. So we're going to touch next. So we're going to palpate from the top to the bottom, both sides at a time, and we're feeling for that symmetrical chest expansion. We're feeling to see if there is any fremitus or any movement with words. So when the patient verbalizes something, breathes in and out, you might feel what's called a fremitus, which is like a vibration. This can indicate fluid buildup in the lungs or problems with respirations. The next step is going to be percuss. So this again is at an advanced level. So for most of your bedside nurses, we're not going to percuss really, but understanding that percussion looks for areas of dullness and fullness, which could indicate fluid buildup or a mass or something like that that is taking up that empty space of the lung system itself. The next step is going to be auscultation. So this is going to be a very important step of the assessment process, is to utilize your stethoscope, listening on both sides of the patient. So we're listening to both sides of the lungs, understanding that we're listening to all of the lobes of the lungs. So one side will have 2 lobes, one will have 3. That right side has 3 lobes because the heart does displace one of the lobes of the lungs on the left side. So you'll listen to the patient's breathing as they breathe in and breathe out on the left side, moving over to the right side, doing the same thing, in and out, all through the lungs. So you're going to do that on the back side of the patient. Then you can also listen to lung sounds anteriorly, so on the front, and then also on the side as well. Since fluid distribution or problems in the lungs where we don't have adequate blood flow, adequate ventilation, those types of things can show up differently depending on where you're listening to the lungs itself. So for your respiratory assessment, we're going to look, listen, palpate, feel, auscultate, those types of things, get a good clinical picture of what's going on with your patient's lungs. You're also going to add in things like any histories and risk factors. Things like, do they have any smoking history, any problems with the respiratory system, any work exposure factors or occupational factors, and then that way we can get a good clinical picture of your patient's respiratory status. This is just a little bit more information, a recap of what I said on the previous slide regarding inspection and palpation of your respiratory assessment. Okay, so a little recap again on the percussion and auscultation of lung sounds. Again, the percussion of the lungs is not really, it's a little bit higher level, so you may not recognize what types of changes there are, which is okay. Just understanding the different resonant sounds, hyperresonant, dull, flat, those can mean different levels of fluid buildup or blockages in the lungs that is offsetting the amount of air that's in that open cavity, which are our lungs. When we're looking at auscultation, it's important to understand different lung sounds. So the next slide is going to have a video with different lung sounds. It is going to be important for you to understand what different lung sounds sound like. So if you were to describe stridor, what would be the words that would indicate that your patient is having stridor? These would be like a high-pitched musical sound. This is oftentimes due to the closing of an airway. So if our patient has airway constriction due to asthma, they may have the sound of stridor. And so be really familiar with what those sound like, how you would describe them, and what might be causing these different lung sounds, especially for testing purposes. So things like stridor. Wheezes would be a, a problem with fluid buildup. So we might have wheezes or crackles if our patient has excessive fluid in the lungs due to fluid volume excess. So look at the trigger words when you're looking through your listing and your education on this for ATI in your textbook on how they describe those lung sounds. But then on the next slide, please listen to those lung sounds so that you would be able to identify what the lung sounds are. The next thing you should do when you're reviewing lung sounds is look at breathing patterns. So the lung sounds are what different sounds you're going to hear, where the breathing patterns is what kind of intake and output of respiratory oxygen and CO2 your patient's going to have. So are they inhaling a long time? Are they exhaling a long time, short time? Are the inhales and exhales maybe in an imbalanced way? So this will make sense when you listen to the next slide. Those are going to show you the breathing patterns and kind of talk a little bit about what those breathing patterns might be from. So for example, our Kussmaul respirations, if you remember back to our endocrine and we talked about DKA, your patient's going to have Kussmaul respirations. In the next video, it will show you what your Kussmaul respirations are actually going to sound like and look like in reference to an extended inhalation and an extended exhalation, but they are at a tachypnic rate, meaning a fast rate. So your patient's going to breathe in for a while and then out for a while, but it's going to be in a fast rate. Cheyne-Stokes, Biot's breathing. So these are some of your patterns that you should be able to identify and talk about what is happening with those breathing patterns. So that would be your next slide for that video. Okay, so now we're going to talk about some common symptoms of respiratory dysfunction itself. Some of these trigger words or symptoms are going to correlate to different disease processes, and we'll talk about that when we break down each one of these disorders. But for the most part, we're going to go over some of the terminology, what it kind of means on this slide. So dyspnea is just a word for difficulty breathing or the feeling of not getting enough air. So this is one of the most earliest signs of respiratory disease and typically our most common complaint. So your patient's going to come in saying, I just feel like I'm not getting enough air. I'm short of breath. I'm having trouble breathing. So this is dyspnea. We might have orthopnea. So orthopnea is actually difficulty breathing when they have different positioning, especially when lying flat. So oftentimes your patient will start to complain about not being able to sleep laying down anymore, that they've had to put a couple pillows behind them, or they feel better sleeping in a recliner chair. They have orthopnea. A cough is just, we all have a cough. Typically, our patients will start to have a cough when we are trying to clear the airway out or as a protective mechanism to expel whatever is in our airway that's irritating. We can have a dry, non-productive cough. This means that there is no sputum or anything that we're coughing up. We can have a productive cough, which might have sputum, and that sputum might look a little bit different depending on what's going on in the body. And they could have an acute or a chronic cough. So sometimes coughs last a long time or they come on suddenly and they don't last a long time. When we look at sputum, this is the mucus or the um, discharge that might occur when we cough or that we have to expel out of our airway. With our sputum characteristics, we have different coloring. So our color of our sputum tells us a lot. If it is clear, then we're doing fine. We're doing great. Our mucous membranes in our respiratory tract are working the way that they should. Sometimes if they become white or thickish texture, this might indicate allergies or some sort of like viral infection. When we have sputum that is a yellow or a green, oftentimes this can indicate an infection of a bacterial route, but not always a bacterial infection. So we really want to do some sort of cultures or testing on that sputum itself. Rust-colored sputum can oftentimes indicate some sort of pneumonia or problems with a pulmonary infection. When we have hemoptysis, this is called bloody sputum. This can be an indication of a severe lung infection, TB, pulmonary embolism, or those types of disorders that would cause bloody sputum. If you see pink tinged frothy sputum, this is an NCLEX trigger word for pulmonary edema. So we're going to talk a little bit more about these disorders, but make sure you understand sputum, what it looks like, and what those little differences in coloring and things could indicate. Besides color on sputum, we also want to talk about the amount of sputum, the consistency. Is it thick? Is it thin? And then does it have any odor? So I say the COCA, the color, the odor, color, odor, consistency, and amount is what you would look at for sputum production. When we look at cyanosis, cyanosis is a lack of oxygen, and this will usually be indicated by a bluish or gray dusky discoloration. Typically, we will see this around the mouth, in the mucous membranes, in our fingernails, or around our lip area. This usually indicates significant hypoxemia or low oxygen in the blood, and this is usually a late sign of that. We might have patients with clubbing. So clubbing is actually an enlargement of the fingertips, where that curvature of the nail is bulbous shaped. This is usually indicative of patients with chronic hypoxemia or low oxygen levels, different types of cystic fibrosis or lung cancer disorders, but it does take a while to develop. So patients with chronic problems with their lungs, you would see clubbing of the fingers. They may have chest pain, so sometimes this is related to a pleuritic cause, so infections in the pleural space of the lungs, that pleural lining that's around the lungs. That can happen when there is pneumonia or infection in that area. Usually, pleuritic chest pain is sharp, and it is worse when a patient is breathing in deeply or coughing. So that is how you would know it's a pleuritic chest pain or a respiratory chest pain as opposed to a cardiac problem. When we look at fatigue, so decreased oxygen will oftentimes cause your patients to be fatigued, lethargic, kind of just worn down feeling because their tissues, their muscles, their cells are not getting enough oxygen. When we have a patient with a change in mental status, like any type of restlessness, confusion, decreased level of consciousness, I want you to start thinking about oxygen as well. So confusion and decreased level of consciousness, that also can be an early sign of hypoxia, especially because our brain really likes oxygen and needs it to function. So decreased oxygen can lead to restlessness or decreased level in consciousness. That's going to be an early sign. Okay, so we're going to look at some diagnostic tools for the respiratory system. When we look at diagnostic tools, one of the easiest thing or the quickest thing that we can do to assess our patient is using the pulse ox or pulse oximetry. This is the little tiny, ET light that we put on the patient's finger. This measures the percentage of hemoglobin that is saturated with oxygen. In a normal healthy adult, we hang out at about 94 to 100%. because most of our oxygen out in the world is actually not 100% oxygen. So we are breathing a fractionated amount of oxygen to begin with. So we usually hang out at about 94 to 100. With our patients who have certain type of obstruction disorders in their respiratory system, like COPD, they will actually hang out at a lower level of oxygen in their norm. And we actually do not want them to be higher in oxygen. So when we're looking at our orders from our provider and we're looking at our patient, it's really important to understand if that patient would actually be harmed by increased oxygen or if they do need supplemental oxygen given to them. So that pulse ox is really helpful for getting a quick, non-invasive, fast reading of oxygen. The problem with this that can affect it is things like nail polish, artificial nails, cold extremities or poor circulation, or just movement itself. Sometimes we're just not getting a good reading. So make sure that line, we call it a pleth line, gives good peaks and valleys to know that it's a really good accurate measurement. Pulse oximetry does not measure carbon dioxide and does not look at ventilation. So we might have to do something that does that. So when we're looking at ABGs or arterial blood gases, this is actually a blood draw that is taken from the radial artery. And this looks at the CO2 level, PaCO2, which reflects how our ventilation is going, and the PaO2, which is our oxygen level, which reflects oxygenation. So our normal CO2 is 35 to 45, and our normal CO3 is 22 to 26. Now, if you remember back to your ABGs and how we will look at that to determine in our endocrine lecture, we looked at it more to determine metabolic acidosis versus alkalosis. With this lecture, we're going to look at it to determine respiratory acidosis or respiratory alkalosis, so problems with the respiratory system. So again, that ABG will evaluate the oxygenation, the ventilation, and then that acid-base balance, which eventually will affect our normal range of our pH, which is 7.35 to 7.45. For our imaging studies, we can do things like a chest x-ray. This helps to visualize the lungs, the hearts, and any structures that are there. This helps to look at any types of pneumonia, pulmonary edema, atelectasis, buildup of fluids on the lungs, those kinds of things. With this, it's quick, it's painless, and we can get a quick imaging of those structures. We will also have something called a CT scan. This looks at detailed sections of the lungs, and this can be a little bit more in depth, looking for things like nodules, tumors, fibrosis, trauma, or things like that. With our CT, sometimes we can use contrast, but remember, if we use contrast, they do have a risk for killing off the kidneys, so decreasing our kidney function. So we want to assess our patient's kidney function if we're using IV contrast. We also want to avoid contrast in anybody that's taken oral anti-diabetic medications because that can cause kidney failure. And then we want to assess them for any contrast allergies. Contrast sometimes can be used just to get a more detailed picture. After you use contrast, make sure to educate the patient to really increase hydration so that the kidney function can still be maintained. When we look at PFTs or pulmonary function tests, these are tests that are used to measure lung volumes and the airflow. Typically, these are measurements for patients that have things like COPD or asthma or lung diseases that would be restrictive to the lung expansion and bringing in air. For these types of things, we'll look at expiratory volume or the vital capacity of the lungs, those kinds of things. But just know that PFTs measure how much volume the lungs can hold and the airflow in and out of the lungs. When we look at sputum culture, remember we talked about sputum. Sometimes if we're seeing abnormal sputum, we would need to take a culture of it or test it to see what types of bacteria or viruses are growing in there. In order to do this, sometimes we might have to do what's called a bronchoscopy. So this is a flexible camera that we place either into the nose or the mouth, and it goes down into the bronchioles and the airway area, looking at the trachea and the bronchi. And we might be doing things like assessing for bleeding, getting biopsies, removing any foreign bodies, or taking sputum samples as well. For our bronchoscopies, because this is a procedure that can be invasive, just make sure that the patient is NPO. They get consent, remove dentures if those are present. Don't give any foods or fluids until the gag reflex returns after the procedure. So that's you making sure that they have a gag reflex so that we don't cause an airway obstruction or potential aspiration. Always monitor breath sounds, oxygen saturation, and then make sure that there's no signs of any bleeding or anything. Okay, so changes in vital signs, any actual bleeding coming from the airway itself. Let's see, so we might also do what's called incentive spirometer. This can be something where it is you guys probably have all seen it in clinicals. This is a type of device where we will have the patient actually place their mouth around the mouthpiece, and they will actually inhale and breathe in as deep as they can. The little thing will raise up and tell you how much capacity their lung is holding, and it will help them to expand their lungs. Incentive spirometer is crucial for your patients to increase lung expansion, which helps to open up those alveoli and help with CO2 and oxygen exchange. So your incentive spirometer is crucial for your patients that are bedridden, not getting up and walking, not able to cough, turn, deep breathe, expand their lungs. Post-op patients, we give those to them. Anybody with breathing problems. I always say essentially every single patient can have an incentive spirometer because it will not hurt them. It will only help them to be able to breathe and prevent pneumonia. You might also see a thoracentesis. So a thoracentesis is a procedure with a needle where they inject the needle into the pleural space, which is that space in between the lung and the pleural covering. And we will sometimes take a sample of the fluid, or we will remove the fluid off of the patient. This can help with breathing, help with diagnostic testing, or help with removal of a pleural effusion. Okay, so now we are going to talk about some disorders specific to the patients with upper respiratory tract infections or disorders. And so we're going to go through that and just kind of recap what the upper respiratory tract areas have. Okay, so we're going to talk a little bit about the disorders for the upper airway area. Now, the upper respiratory disorders, airway disorders usually don't directly affect gas exchange because those lung tissue and alveoli are intact and functioning. But sometimes if we have airway obstruction, then this can cause problems with the patient or life-threatening problems. So we'll talk a little bit about a couple not not really deadly or serious things that we can see in our patients. So we have rhinitis. This is our common cold. This typically you'll see inflammation of the nasal mucosa due to those viruses. It can also be due to allergies or other irritants out in our environment. What you're going to see in your patient with just typical rhinitis is going to be things like sneezing, runny nose, maybe some mild sore throat, cough, nasal congestion, and then sometimes a low-grade fever. For these patients, it's basically symptom relief. So we're doing rest, hydration. We might do a little bit of saline nasal spray to help humidify and moisturize the nasal passages. But for viral rhinitis caused by viruses, we would not give antibiotics since antibiotics only kill off bacterial infections. For sinusitis, this is an inflammation of the paranasal sinuses. So that's those sinus areas or those sinus cavities up above our nasal area. These are usually caused by bacterial infections, although we can have viral infections as well. We can also have causes due to seasonal allergies or environmental allergies. For this, most of the time your patient will have facial pain, especially in the sinus areas when pressure is applied. They may have a headache or some type of nasal drainage and congestion. This also can travel down into the tooth area, so they'll have tooth pain up in that top part of their mandible. For this, most of the time, antibiotics, if it is a bacterial sinusitis and it's confirmed through cultures of the sinuses, but oftentimes we'll do decongestants to help thin the mucus trapped in the sinuses, and we may do things like saline irrigation to kind of flush it out and clean it out. We do see that the pain sometimes gets worse if patients kind of lean down and bend forward, because all of the pressure from that mucus buildup will actually press against the sinuses as well. Pharyngitis. So pharyngitis is an inflammation of the pharynx, most commonly caused by viral causes. We see this a lot with group A strep. So this is strep throat. Our patients will have sore throat, difficulty swallowing. They may have swollen or painful lymph nodes, especially those cervical ones by the throat. Fever often occurs as well. So we'll do things like a strep throat culture, see if it is a bacterial infection. If it is, we can give antibiotics. If it is not a bacterial strep or a common cause there, then we would not give antibiotics. We would do supportive care like warm saltwater gargles, hydration, and pain relief. We then can have epistaxis. So we're going to look at this on the next slide as well. But this is a nosebleed. Our epistaxis is our nosebleed that we will see in patients that might have problems with nose picking, dry air, but it could be caused from trauma, use of anticoagulants, or things like that. There's going to be two different types of nosebleeds that we're going to talk about, and our nursing interventions will be slightly different depending on what we're going to do for that patient. For both patients with a nosebleed, we actually want them to sit upright and lean their head slightly forward, not back, because that will cause the swallowing of blood and can increase the risk of nausea or aspiration. They will want to pinch the part of the nose that's right underneath their nose bone, so that soft part, for about 10 to 15 minutes before they check to see if there's any bleeding, just to make sure that nose clots off. They can also apply a cold compress, like an ice pack, to help vasoconstrict those little capillaries that are in the nose that might be bleeding. For your laryngectomy, this is a area with a problem of the larynx or the voice box. Sometimes we can have infection like laryngitis that can be a cause from a viral infection, smoking, GERD or gastroesophageal reflux, which we'll talk about in GI, or overusing our voice. Typically what we'll see is a hoarseness or a loss of our voice or a dry cough. For this, we'll want to rest our voice, do plenty of hydration, and humidify the air if we can. Again, with any respiratory system dysfunction or education, avoiding smoking, cigarette smoke, vaping, secondhand smoke, or any type of illicit drugs is going to be crucial for our respiratory system. Okay, so for our two different types of epistaxis or nosebleeds, we have two different kinds here. We can have a frontal nose bleed. This we see most commonly in kids. This is oftentimes due to just a bleeding of the little tiny capillaries that are inside the nose. And what we find is that those capillaries just kind of burst open because they're fragile and they're close to the surface of the skin. And so they start to have a nosebleed. Again, with these patients, we want to sit upright, lean slightly forward, pinch the nose for about 10 to 20 seconds, not, I'm sorry, 10 to 20 minutes, that'd be better, to make sure that that bleeding stops. For these patients, we want to avoid any blowing of the nose or heavy lifting, which can cause the clot to dislodge. Sometimes we can use topical nasal sprays, things like Afrin or things like that that will actually help constrict the capillaries. For your elderly patients, what we see is actually a posterior nasal bleed, which is further back in that nasopharynx area. And what we see with them is that pressure on the nose, even after 20 minutes, 30 minutes, an hour, they just will not stop bleeding. Or they have recurrent episodes where they stop bleeding for just a short time and then they start bleeding again. With these patients, and oftentimes it's in our elderly population, they will come into the hospital seeking treatment for bleeding. And what we will do with them is we'll actually do what's called a rhino rocket or nasal packing. It essentially just looks like a tampon that we shove up in their nose. It helps hold pressure, it packs it, and it stops that bleeding. They sometimes will give local anesthetics or vasoconstrictive medications if the packing does not stop that nose bleeding. But those are your two different types. As always with epistaxis, you want to make sure that the airway is not compromised by the draining of blood back into the throat. So that's one of the main important things. This is just going to be a visual comparison picture for you to see the different cues, treatments, kind of focus for the different upper airway infections, rhinitis, sinusitis, pharyngitis, and laryngitis that we already talked about. This slide shows laryngectomy care. So if a patient has laryngitis or if they have some sort of tumor or blockage in their larynx area, they will actually take out or remove the pharynx or the larynx area and actually create an artificial opening called a stoma right into the trachea and esophageal area. This is an opening here where we will have a tracheostomy. So you guys, I think, have seen that in Skills Lab. If not, go take a look at it in Skills Lab. Look at what it looks like. Pull it out of the mannequin. But it's a tube that goes in there, and this is what is creating their airway. So their airway is actually in their neck area, no longer in their mouth. So when we're doing things like uh, emergency care, if they stop breathing, we're actually not going to do an ambu bag over their mouth. We will do it in their tracheal area on that tracheostomy tube. So for that stoma care, things we want to do is look for bleeding, make sure the opening is clean, dry, intact, there's no problems there. We don't make sure that they don't have any water or things that go in there. So swimming, bathing, those kinds of things. Just be careful with showers and introduction of water into that area. Because the air does not go in through their nose anymore and in through those turbines to get humidification and warmed, you probably will need to add humidification and warm oxygen if used. Because they don't have a really good ability to handle secretions anymore and swallow those down, you might have to do suctioning, which you guys learned about. I think you did that in funds, or you might be doing it in this class in Skills Lab where you're doing trach suctioning. Now, because that does go into the respiratory system, your respiratory system is sterile, so it is a sterile procedure. So anytime you put anything into the patient's stoma or down into their respiratory system, it needs to be sterile. This can remove their larynx, which is that voice box, so the patient may lose the ability to speak. So communication aids would be crucial. Things like picture boards or words, or have them write it out so that they can still communicate. Excuse me. Um, Always paying attention with respiratory system and anything like that to do your ABCs. So airway, breathing, circulation. I actually call it the ABCDs, airway, breathing, circulation, and then the rest of it, which is your psych, social stuff, pain, stuff that is not going to kill your patient. So when we're looking at respiratory system, if they have a problem with their airway, loss of airway, bronchoconstriction, closing of the airway, that's going to be your top priority and the person that will die the fastest. So paying attention to that. With this laryngectomy, their airway is different now. So it's actually on their neck. So remember, they have a higher risk for aspiration and they will have a higher risk for loss of airway. Okay, now we're going to do chapter 19. This is going to be problems with the chest and lower respiratory tract disorders. So we'll talk about these diseases. All right, so in this section, we're going to talk about lower airway disorders. These are going to be disorders or problems that impair ventilation, diffusion, and or perfusion, which will lead to hypoxemia itself. So this is usually problems of the lungs or the circulatory system affecting the lungs. We will talk about atelectasis. So atelectasis is the collapsing of those alveoli. So remember those little bunches of grapes, they should be nice and open and able to have the perfusion and the ventilation. But this atelectasis is where those bunches of grapes collapse, so they become flattened. And so oftentimes this decreases our ability for our patients to have oxygen and CO2 gas exchange. What we will see in our patient is going to be things like dyspnea, difficulty breathing, low oxygen saturation on that pulse ox. We might have mild fevers because there could be a start of a little inflammatory process and infection process there, and then we'll have decreased breath sounds. To prevent atelectasis, we will utilize that incentive spirometer, so getting those lungs expanded, keeping those alveoli open, doing things like turning, coughing, and deep breathing to be able to clear out the alveoli, and then early ambulation. That is key. So get them up and walking as soon as they can. This is especially important for our post-op patients to make sure that they don't develop atelectasis or pneumonia. For our pneumonia, so this is actually an infection inside of the lung tissue. Oftentimes, the infection causes the inflammatory process and inflammation to occur, and it leads to fluid buildup in those alveolar sacs. Bacteria and virus can enter into that lungs, cause that inflammation to occur. Fluid and pus can fill the alveoli up, and it decreases our ability for the alveoli to exchange that gas. So CO2 levels build up, oxygen levels are decreased. So what you'll see in your patient are going to be a decrease in oxygen, fever, productive cough. They're probably going to have pleuritic chest pain, maybe some crackles or dyspnea. This is oftentimes treated with antibiotics if it's a bacterial cause. So we'll know that by some cultures. Oxygen, early ambulation, get them up, walking, do that incentive spirometer, and then lots of hydration. We will look at COPD. So again, COPD is chronic obstructive pulmonary disorder. And so this is where that airway is actually obstructed. Oftentimes this occurs from a inflammation or a not reversible limitation to the progressive airflow there. COPD is an umbrella term that we oftentimes, it is a diagnosis, but it also can be an umbrella term for bronchitis or emphysema. This is where those bronchioles can be narrowed, or excessive mucus production can decrease the airway itself. And so then we'll have things like air trapping or increased CO2 levels. For these patients, we'll do things like bronchodilators, open up that airway. They may do corticosteroids to help decrease the immune system, help decrease swelling. Oxygen as prescribed, because remember, for our COPD patients, we do not want to over-oxygenate them because their respiratory drive will actually be decreased. These patients are used to staying at a high level of CO2. So when that CO2 gas is not there to trigger our body to, or when our CO2 gas is there, In a normal patient, it triggers our body to breathe more, breathe faster, to bring oxygen in to decrease the CO2 level. In a COPD patient, they are used to hanging out at a higher CO2 level. So if we give them oxygen, then their body will essentially kind of stop breathing because the drive demand of that CO2 oxygen exchange is actually decreased. So COPD patients like COPD, emphysema, or some chronic bronchitis, those obstructive disorders, make sure to monitor them for oxygen, and we may only keep their oxygen at a 92%. So that's about as high as they're going to go for their oxygen. For our patients with TB, so TB is an infection that we're going to talk about caused by the Mycobacterium tuberculosis infection. There's going to be some NCLEX-Q symptoms. So these patients will have chronic cough. They're going to have hemoptysis or bloody sputum. They're going to have fevers, weight loss, night sweats. So those are going to be some of the cues that you're going to go, oh, I bet they have TB. You're going to ask them if they've been doing any traveling recently from an outside country, since TB is a higher risk in some of those areas. And then we'll do things like some diagnostic testing and some treatment. We're going to talk about that on a next slide because, or not the next slide, but one of the next slides, because we're going to talk about some pretty in-depth treatment and things like that. Then we have ARDS. So ARDS is acute respiratory distress syndrome. This is a severe inflammatory lung injury that leads to pulmonary edema, which is a swelling of the lung tissue, and complete respiratory failure. So what that actually happens is that the lung tissue will actually become stiffened, and so it can't stretch out, you can't really increase respirations, and then that CO2 gas exchange does not occur there. These patients also remain hypoxemic even though we develop or give them higher concentrations of oxygen. So what you're going to see in your patient will often be very severe dyspnea. They're not going to have oxygen levels that increase. They're going to have refractory hypoxemia, and then they're going to have an increased work of breathing. We will diagnose this by looking at chest x-rays and oftentimes looking at the tissue itself for ARDS. ARDS is something that you will go into in complex care. So that's going to be something that I'm going to just briefly touch base here, but we're going to go more in depth in complex care. Occupational lung disease is lung disease that you can get from occupational exposure. So things like asbestos, mesothelioma, those types of things where an individual is at work and has exposure to something that has damaged their lung tissue. Then we'll talk about lung cancers. So lung cancers, again, we will talk about or have talked about in our oncology lecture, but lung cancers are often a sign of like pulmonary nodules, growths in the lung tissue, which decreases oxygenation. It can have challenges with perfusion and things like that. So oftentimes what we'll see for lung cancers is a use of smoking or occupational exposure to something that's a carcinogen that's caused cancer. Now, not always, because sometimes we can see patients who do develop lung cancer, they've literally never smoked a day in their life. But for NCLEX and testing purposes, lung cancer is typically highly caused by smoking. So smoking cessation would be required. So we'll go a little bit more in depth on some of these diseases, but this is what we're going to talk about in this lower airway disorder area. Okay, so here again is atelectasis. So this is that collapsing of the alveoli. So if you see there in the little picture, those little red bunches of grapes, these can collapse and fill with some fluid so that CO2 oxygen exchange is not occurring. This is most highly at risk for our patients that are immobile. They're not able to get up, they're not able to cough, turn, deep breathe, and really expand their lungs. Or patients that are post-op, and that's because they're laying in bed, they've maybe gotten sedation, they're not breathing as effectively, and so those alveoli can collapse. Atelectasis can occur in literally 4 hours or less, so it's like very quick that can occur. So we just want to monitor for patients for signs and symptoms of atelectasis and really give them that incentive spirometer. With our post-op patients, keep in mind that if they've had surgery somewhere where it's going to be painful for them to take deep breaths, make sure that we give them pain medication before we have them use the incentive spirometer. And then we can do something like splinting, whereas like that's where they hold a pillow up to that painful area and kind of put pressure on it when they take a deep breath in. That should help them be able to take a deeper breath in. Atelectasis is something that's very important to understand, and it's a nursing intervention through and through for a lot of your patients there with the use of that incentive spirometer. Okay, here's a slide again talking about pneumonia or those pulmonary infections. This leads to a buildup of fluid in those alveoli. So what we're going to see is decreased oxygenation. That CO2 gas exchange cannot occur. They may have productive cough, trying to get that fluid and that sputum out. But what you'll see is decreased oxygenation and signs of some sort of an infection, fever, productive cough, those kinds of things. For your pneumonia, it's diagnosed through the use of sputum cultures, X-rays, imaging, those kinds of things there to diagnose pneumonia. Okay, so here's where we're going to go a little more in depth on tuberculosis or TB. So this is a contagious bacterial infection. It is caused by the Mycobacterium tuberculosis or tuberculosis bacteria. It most commonly affects the lungs, but it can spread to other organs. But what we'll typically see is that a patient has different types of areas of necrosis. So they're like little capsules or granulomas inside the lungs. This is because they have the immune system, which walls off that bacteria and causes a wall around the tuberculin bacteria and helps prevent the spread throughout the lung tissue. With our patients with TB, again, your symptoms are going to be things like fever, a cough, persistent fatigue, night sweats, weight loss, bloody hemoptysis or bloody sputum, and then chest pain. If you see a patient with a cough, night sweats, weight loss, you're going to think TB. And so what we want to do is we first want to put them in isolation because this can be very contagious. When we put them in isolation, they need to be in a special isolation. This is called a negative pressure isolation or airborne precautions. This is where the air will actually be taken and circulated from the room and put directly outdoors so that the tiny little particles of bacteria that are spread in the air cannot be spread from person to person. When you go in an airborne isolation room, you're supposed to have a fitted respirator. This is called an N95 mask. This helps to filter out the teeny tiny particles that can be infectious. When the patient leaves the room, they only have to wear a surgical mask. So you going in the room wears an N95. When they come out, because let's say they need to go down for an MRI or a test, they would wear a surgical mask. Other precautions for them are going to be things like limiting exposure to other people. So this can be very isolating. They typically will stay in the room. They're on that negative isolation. They don't come out. People don't go in and visit. So it's a little bit isolating. So we could do things like give them their cell phone, do video conferencing with their families or things like that, just to decrease them transmitting that to other people. Now, when we look at treatment for TB, this requires multiple different antibiotics and it's over the course of several months. So some of the medications that they will require, let's see, did I put it on here? No. Okay, so you'll want to write this down. So the medications for TB is, the acronym is RIPE therapy, RIPE. So one of the medications is called rifampin. So rifampin is one of the medications, an antibiotic. They're going to have to take this for several months. One thing to note with the use of rifampin is that it has a lot of drug interaction, so make sure to check your drug compatibility, but it also can cause body fluids like sweat, tears, urine to turn a orangey red. So this doesn't indicate bleeding, it's actually a side effect of the medication. The next medication is isoniazid. So this is another antibiotic, but it does have a risk factor for hepatotoxicity. So watch liver enzymes or labs, and a risk for peripheral neuropathy. The third medication is pyrazinamide. There we go. I got it. Pyrazinamide. This medication can cause an increase in uric acid, so monitor that lab value, and it can also be hepatotoxic. So while they're on these TB medications, we are looking at liver failure or liver labs. Then the next medication, the final medication, is ethambutol. They will take this medication, again, another antibiotic medication, but this medication should be monitored because it does have changes in vision. So if your patient starts having any red, green color problems in their vision, make sure to assess their visual changes here for this medication. So to note, it's the RIPE therapy. Rifampin and isoniazid is the two that are usually tested on very heavily for NCLEX. Just knowing that they cause orange-red body fluids, have a lot of drug interactions, and then are very hepatotoxic. So just make sure that you understand that teaching for the patient and the fact that they'll be on these for several months. Making sure for TB we do airborne isolation, good, teach the patient cleanliness, wash their hands, cough etiquette, cover their mouth when they're coughing, to try to keep their airway or their not airway, their environment clean. We will want to look at ABCs, so monitor airway, breathing, circulation. D for the rest of it might be things like feelings of isolation. Okay. Making sure that the patient takes those TB antibiotics for the entire prescribed course, because if they stop it when they feel better or they feel their symptoms improved, then they can develop drug-resistant TB, which is really bad for them. Okay, this is just a reminder here to look at occupational lung disease. So things that can help prevent this, work exposure would be things like correct PPE. So respirator masks, surgical masks, N95 masks, things that can help prevent a lung exposure or respiratory exposure. Workplace monitoring, so things like air quality, chemical exposure, and then smoking cessation, looking at environmental testing, like testing for asbestos. For lung cancer, we are going to talk about cancer in oncology and kind of talk about tumors and how they grow. But for lung cancer specifically, just understand that it is an uncontrolled growth of abnormal cells inside of the lung. So the lung cells tend to divide uncontrollably, which ends up forming tumors and can invade that nearby tissue. These lung cells or tumors can actually metastasize or spread to other parts of the body. It is one of our leading causes of cancer-related death, because usually lung cancers are diagnosed at a later stage. For your patient with lung cancers, the biggest risk factor, again, is cigarette smoking. So we want to make sure that we decrease the number of cigarettes patients are smoking and helping them to stop smoking. So it's really important to educate on smoking cessation. Other risk factors, however, can be things like secondhand smoke exposure, exposure to different occupational hazards like asbestos or radon, chemical exposure, or we can have an increased risk with family history. We have a couple different types of lung cancer. We have small cell lung cancer and non-small cell lung cancer. Non-small cell lung cancer includes things like adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Usually, these non-small cell lung cancers grow slowly, more slowly than small cell. Our small cell lung cancers are a little bit less of our lung cancers at about 15% of what we see. These grow rapidly. They tend to have early metastasis or spreading. This one is a higher association with smoking and is usually treated with chemotherapy and radiation instead of surgery. For our patients with lung cancer, most of the signs and symptoms we're going to see are things like changes in their cough, a persistent cough, hoarseness, or recurring infections like pneumonia. They may have bloody sputum, and then they may have systemic symptoms like weight loss, fatigue, and loss of appetite. Since cancer from lungs can metastasize, oftentimes we will see tumors found in the brain, bones, or liver as well. Okay, now we're going to talk about chest tubes and chest tube management. Chest tubes are something that is very highly tested in NCLEX and on testing, exams. With our chest tubes, these are a sterile tube that is typically inserted into that pleural space. A lot of times our patients need chest tubes and drainage due to complications or traumas like a pneumothorax, which is fluid buildup in the thorax or thoral space, hemothorax, which is blood built up in that pleural space, or flail chest, which is a type of breathing that you'll see where the patient's chest is expanding asymmetrically. For our chest tubes, they can help remove air, fluid, or blood in that pleural space. So we might see things coming out of that chest tube drainage, or it may just be air itself. Removing these substances help to let that lung re-expand and can help improve ventilation. So typically our normal pleural space has about 5 to 15 mLs of fluid in there, and it's used for lubrication. It has a negative pressure, which helps to keep the lungs expanded during breathing. When air or fluid or something enters that pleural space, that negative pressure is actually decreased or lost and causes the lung to either collapse completely or occasionally can only collapse in part of the lobe of that lung. So again, this chest tube can help restore that negative pressure by either taking out unwanted air or fluid in that pleural space. When we look at placement of the chest tube, this is typically done by a provider, by a doctor. It is a big, long needle that is inserted between the ribs, excuse me, into the pleural space. And then that tube, that catheter is attached to a drainage system. There's a couple things to note for the drainage system. Again, this should be always remain sealed and continuous so that it remains sterile. There's no loss of air or anything that could cause the lung to actually collapse or recollapse. The drainage system itself, the canister or the collection device, should always remain below the level of the chest so that we don't have a backflow of any type of fluid. When we look at our chest tubes, there's a couple things to note on the chest tube. And you'll see the chest tube in a later slide as well. And I think I have a video that talks about chest tubes here as well. So we have a 3-chamber collection device system. So the first chamber is the collection chamber itself. This is what's going to fill up with any blood, fluid, or pus that we need to actually drain off of the patient and out of that pleural space. The nurse's responsibility is to make sure to document the amount and the color and measure the drainage itself to see, is that drainage increasing, decreasing, or kind of staying the same in amount. We want to make sure to monitor and watch for any sudden changes in the amount. So we don't want to have a bunch of fluid suddenly dump out or a big increase in collection. And then we want to make sure that the drainage itself does not increase in blood, go from maybe a serous, sanguineous, pinkish tinge drainage to all of a sudden bright red blood. So it should be getting better, not worse. Initially, when that first is inserted, we can have bloody drainage, but later, as the fluid is drained and that pleural space is cleared out, it should go from a serous sanguineous to a serous. Notify the doctor immediately if there is a sudden large increase in drainage. Anything, more than 100 mLs per hour, bright red bleeding, or any stopping suddenly of drainage, because that may indicate an obstruction. The next chamber that we have is what's called the water seal chamber. So the water seal chamber actually acts as a one-way valve. So this allows air to go out and prevents air from coming back in. So air is able to go out of the lung when we have excessive air, not the lung, the pleural space, and it's actually going to prevent air from going in. This is so that that lung remains fully expanded and does not collapse. What we see in our water seal chamber normally is that that water level will rise up during inspiration and fall down during expiration. So this is called tidling. So it's kind of a increase and decrease and kind of a waving appearance that you have. And it's correlated to when the patient breathes in and breathes out. Tidling means that the system is working as normal and that it's patent. If you see any type of continuous bubbling in the water seal chamber, this would not be normal, and this could indicate an air leak. So what you'll want to do is check areas of tubing to make sure there's no holes or tears, check the connections to make sure they're properly sealed, make sure that that insertion site on the patient is not having any signs of leaking, the dressing is intact, and that chest tube is inserted correctly. So continuous bubbling in the water seal chamber is not normal and needs to be addressed, checking for any leaking. If you don't find any signs of leaking, we would want to notify the doctor to assess and change out that chest tube. The third chamber is the suction control chamber. This provides suction when ordered by the provider. Typically for wet suction, this is usually filled to the -20, and you'll see that on the little dial area off to the side of the control chamber. This, in the suction control chamber, can have gentle bubbling. So a bubble every once in a while is okay in the suction control chamber. Sometimes we can see the suction control chamber is what's called a dry suction. This uses a regulator instead of water to create that suction. In this area, usually there is no bubbling. So main things to notice and do, so our nursing responsibilities for a chest tube is to keep that drainage system below the chest. This helps prevent backflow. It helps to prevent re-entry of air or fluid into that pleural space that we're trying to drain. We'd never want to clamp a chest tube. Clamping can actually cause a tension pneumothorax, so it can cause swelling inside that pleural space. So we will only clamp briefly if the provider orders it, or if we're trying to troubleshoot leaking and we're clamping with rubber tipped clamps in different areas of that tubing. We will never strip or milk the tubing routinely. That's where we take the tubing and we kind of like pull on it to try to get any clots or fluids or anything out of it. This is called stripping or milking. We don't want to do that because that can cause high pressure in the lung and can damage lung tissue. So that's actually old habit there. We do want to make sure to assess the patient frequently. This is going to include oxygen saturation, breath sounds, respiratory rate, watching for any pain, making sure the patient has adequate chest expansion and they're breathing okay. They may also have signs of what's called crepitus, and this is actually a trapping of air underneath the layer of the skin. When you're assessing the patient, you'll assess for crepitus at the insertion site where that chest tube goes in the rib area, and you'll do this by palpating and feeling for that air underneath the skin. This feels like Rice Krispie treats. So when you push down, it kind of feels like you're pushing on a Rice Krispie treat. So it kind of has that crackling feeling. We're assessing the insertion site. We're looking for any redness, swelling, drainage, dressing integrity, and air leak. Now, we do have some responsibilities for emergent care with the chest tube. So if the patient's chest tube becomes disconnected, meaning the area that is in the patient, the little catheter tip, becomes disconnected from the drainage tubing, you'll want to take the end that is inside the patient's chest and place that in a bottle or a container of sterile water. This is to buy you some time to go get a new drainage system. This is temporary and creates a water seal so that air is not going back into the pleural space. We'll want to go ahead and grab a new drainage system, notify the doctor if necessary, and reattach that sterile drainage system. If the chest tube comes out of the patient completely, meaning the little catheter part that's inserted in between the ribs comes out, which this doesn't often occur because they're usually like sutured in the patient, but if it does, then what you'll want to do is utilize a sterile occlusive dressing, usually like a Vaseline gauze or something like that, and tape it on 3 sides. That creates a flutter valve that lets the air come out but blocks air from coming in. So a occlusive dressing taped on 3 sides is if that chest tube comes out of your patient. You will notify the doctor immediately for potential reinsertion, and you'll assess respiratory status, lung sounds, pulse oximeter, and those kinds of things. Sorry, that was my timer. The chest tube will usually be removed when the lung has been re-expanded. If drainage has significantly decreased to where we kind of have cleared out that pleural space, or if any air leaking or air problems in the pleural space has resolved. How you will know that is that there probably will not be any titling and no bubbling inside the chest tube at all. That's usually how we'll know that that lung has re-expanded or that drainage has decreased. Okay, so to recap, we want to make sure that titling is okay. That's the breathing in and out. So you'll see the waving of the fluid in the water sealed chamber. If we see continuous bubbling, this is a sign of an air leak. So continuous bubbling is bad. Any signs of infection like fever, drainage, or redness at insertion site. The crepitus or Rice Krispie treats underneath the skin could mean that there's air leaking under the skin or trapping under that skin. And then any sudden severe problems breathing, tracheal deviation, so that's the trachea moving to the side, absent or decreased breath sounds, hypotension, or just any signs of the patient not breathing normally, panicking, any problems like that, you would want to notify the provider and monitor the patient. Make sure that collection device remains below the chest. Never clamp it routinely. And then at bedside for your emergency things, you should have rubber tipped clamps if you need to check for oxygen leaking, but never leave the clamps on. You should have an occlusive dressing that you tape on 3 sides and a bottle of sterile water to put the end of that chest tube in if it becomes dislodged. I would recommend reviewing chest tubes, knowing chest tubes, and making sure you understand nursing interventions, how to watch for emergencies, what to watch for, how to know if it's working correctly. There should be a video on the next slide for you to review as well. In the next couple slides, we're going to talk about patients with chronic pulmonary diseases. Okay, so we briefly talked about COPD, or chronic obstructive pulmonary disease. This is an umbrella term, sometimes a diagnosis that we will see for our patients, but it encompasses the actual diagnosis of COPD, asthma, bronchiectasis, and cystic fibrosis. So these diseases are progressive, often irreversible, and they're basically problems with airflow limitations. So it's an obstructive disorder. These patients have difficulty ventilating, so they have problems moving air out of the lungs as opposed to moving it in. And oftentimes this will lead to impaired gas exchange, specifically increased CO2 levels. So they usually will have things like air trapping, increased CO2, problems with respirations, and then chronic inflammation. Two major disorders in the COPD branch or umbrella is chronic bronchitis and emphysema. So you might hear them referred to as blue bloater and pink puffer when you're studying, and it might help you kind of visualize what they look like. So chronic bronchitis is a blue bloater and emphysema is a pink puffer. So we'll talk about that. So thinking back to our normal pathophysiology, our normal lungs have open airways, which lead to normal alveoli where that airflow goes in and that normal gas exchange can occur. With COPD diseases, chronic inflammation can lead to bronchial narrowing and excessive mucus production. This leads to air trapping and can lead to hyperinflation of the alveoli, which can lead to destruction of those tiny little grapes. This leads to poor gas exchange and can lead to increased CO2 and decreased oxygen, which can lead to hypoxemia, which is decreased oxygen, and hypercapnia, which is high CO2 levels. Oftentimes, our most common cause, our primary cause, is cigarette smoking. Other causes, though, can be our occupational exposures, air pollution, secondhand smoke, those kinds of things. Some genetic deficiencies, especially in our younger patients. So with our chronic bronchitis, this is an inflammation of the bronchi that causes excessive mucus production. Most of the times, what you'll see in your patient is a productive cough that usually lasts anywhere from 3 months to 2 years, leads to inflammation, super thick mucus, narrowing of the airways, and poor ventilation. So they do lead to having low oxygen. So they are hypoxemic. Their symptoms, they're going to be cyanotic. So there's your blue. They're going to have a chronic productive cough. They're probably going to have dyspnea. And then they will have probably frequent respiratory infections. So they are going to be blue bloaters. For your other patient, emphysema, these are going to be your pink puffers. So emphysema patients have a destruction of the alveolar walls, which causes those alveoli to lose their ability to stretch and recoil. So those alveoli break down, which leads to a decrease in that surface area. So there is poor diffusion, leading to air trapping and hyperinflation. So we will have a barrel chest. A barrel chest is a disproportionate is the word I was looking for, disproportionate shaping of the chest. So instead of having kind of an oval shaped chest like we do, their chest, due to that constant hyperinflation of their lungs, will actually be the shape of a barrel. So their chest is like really rounded and broad. Their other symptoms are going to be things like pursed lipped breathing. So that's where when they breathe, they actually will do kind of a, you remember like back in the day, duck lips? They'll breathe like that. And then when they breathe out, they're doing the duckbill breathing. So it's like really long breathing out. They have progressive dyspnea, so difficulty breathing, and kind of a thin appearance. These are your pink puffers because they're puffing with that barrel chest and then they're having that purse-lipped breathing. Some patients for our COPD patients can have overlapping symptoms. So just know that anything that has a problem with obstruction in that airway, increased inflammation, increased mucus production would probably fall under this COPD patient. With their respiratory, some of the NCLEX trigger words that we'll recap is going to be things like wheezing, prolonged expiration, dyspnea, and diminished breath sounds. They are probably going to have pursed-lipped breathing, which helps to kind of change their CO2 levels. With pursed-lipped breathing, they will actually kind of help retain the CO2. They retain the CO2, they retain CO2, but it kind of helps to not get rid of the CO2 too easily through excessive breathing. It kind of slows that down because remember, their drive, their respiratory drive is altered. So we don't want them to have decreased CO2 because they'll stop breathing. So we just want to decrease the CO2 to a certain extent, but still hang on to some of it. They will have a barrel chest. They will have accessory muscle use, so those intracostal muscles will be seen when they're breathing. And then tripod positioning. So this is where they will actually kind of hunch over onto a table and kind of expand their lung capacity a little bit more. So you'll see those words: tripod positioning, pursed-lipped breathing, barrel chest, diminished breath sound, prolonged expiration. I'd like you guys, because I can't show you what they look like, I try to look up those physical findings so you see what they actually look like with like the tripod positioning. For some of our late findings and trigger words, we'll see things like cyanosis, so that bluish tinge or grayish tinging to the skin, the mucous membranes, and the lips, and clubbing. And remember, that's in the fingers there. That is common in COPD, but it's usually like a chronic lung disease as well. So, and because this is a buildup of that CO2 over long periods of time. Let's see, so COPD. So some of our treatments for COPD, most important is to stop smoking if that's a cause or a risk factor for the patient. This helps to slow down the disease process. Remember, this is not reversible, but we can slow it down a little bit. We will give medications that help to open up the airways because it's an obstruction of the airway. So we'll open up those airways by giving bronchodilators. These are going to be your short-acting or SABAs and your long-acting or LABAs. One of our short-acting medications that we give a lot, especially if they're having chronic problem, or not chronic, acute problems with their chronic COPD, like acute breathing problems, we'll give them albuterol. That helps open up the broncho constriction. Your LABAs help to relax the bronchial smooth muscles and help to improve air blood flow. These we will typically give to our patients for those chronic COPD things to help breathe longer. So those are long acting. Sometimes we can use inhaled corticosteroids with patients that kind of have frequent exacerbations of this. This can help reduce airway inflammation and help to decrease those exacerbations. But remember, we don't want to put people on corticosteroids because we risk things like Cushing syndrome. So we don't want to do it unless really necessary. For your oxygen therapy, remember your patient should not be titrated or, given oxygen to high levels. We want to keep them at around 92%. That's usually the target, 88 to 92%. We will not withhold oxygen from a patient though, especially if they're super low. So we just have to be careful to just try titrate it specifically and use, not too high levels. We can educate on breathing techniques. So pursed-lipped breathing. This is inhaling through the nose, exhaling slowly through those duck lips, pursed lips. This helps to prevent airway collapse, so kind of keep those alveoli open. It helps improve oxygenation and helps with that CO2 oxygen exchange and just helps them breathe a little bit better. For your patients thinking about nutrition, they also may take a high calorie, high protein diet because excessive breathing and problems with respiratory systems can require increased metabolic demands and nutrition needs. Let's see. I think that's it here on this slide. Yeah, we're good on this slide. All right, so we're going to go ahead and review oxygen delivery devices. You guys learned this, I think, in fundamentals. You guys have probably had a chance to go over it in a practice lab. So just make sure to go review these and kind of look at them and be familiar with these for your patient use. So when we do oxygen delivery devices, this is to provide oxygen therapy so that we can give patients supplemental oxygen. This helps to treat hypoxemia, that low oxygen, and not just like that dyspnea by itself. So we really want to make sure we assess the patient and we see that their oxygen level is low by the use of the pulse oximeter. We can use different devices depending on how much oxygen they need. So first of all, we have our nasal cannula. This is that little nasal oxygen device that sits right inside the nostrils. Our oxygen flow is about 1 to 6 liters for this one. When we get up to 5 to 6 liters, just make sure that we humidify that oxygen because it can be very drying to the mucous membrane. So that's where we put the little bubbler thing on the oxygen. We always want to assess the skin breakdown inside the nose to make sure that we don't cause any wounds or anything like that. So the advantages of nasal cannula is that patients can still eat and talk. It's super easy to apply. It's pretty comfortable, but there are a couple disadvantages like the lack of liter concentration, so we can only go up to 6, and then patients who breathe through their mouth may not really be getting full oxygen. The next thing we'll have is our simple mask, so this covers the nose and the mouth. This oxygen flow should be between 5 to 10 liters. Never want to use it below 5 liters because that mask can actually accumulate carbon dioxide that's been exhaled from the patient. So we really want to have a high enough oxygen level to blow that oxygen and get rid of it. For our simple face mask, this is good for our mouth breathers. This might be something that we use a little bit short term, so not too long, just because we do have that CO2 buildup there. For our next one, we have our partial rebreather and our non-rebreather mask. So our non-rebreather mask has a reservoir bag and one-way valve, and it is usually used for oxygen 10 to 15 liters per minute. This is used for our severely hypoxic patients, patients with respiratory emergencies, and it usually buys us a little bit of time before we have to intubate the patient. Make sure to keep that reservoir bag like inflated during inspiration. That way you know that the oxygen is there. If that bag becomes deflated, make sure to kind of open it up and increase the oxygen flow, or else we have a buildup of CO2. For your partial rebreather mask, this is a mask that has that reservoir bag, there are no one-way valves. So some exhaled air mixes with the fresh oxygen. This is a 6 to 10 liter oxygen as well there. And so this one, the partial rebreather, may not have that bag fully inflated. So be sure to know which one you're using on your patient. The non-rebreather is our most common that we'll see in the hospitals and facilities that we use for those emergent needs. We then have a Venturi mask. So this is a mask that has those little tiny colored little dials that you can put in, that you can fit into that mask. This is used to provide a precise fixed oxygen concentration. So those little tiny different colors have a different oxygen concentration that is able to like dial and be flowed through. Venturi mask is basically used for COPD patients who need controlled oxygen delivery. Your final one is a high flow nasal cannula. And so these are patients who are on a very high amount of oxygen. This is up to 60 liters per minute. These patients require super high levels of oxygen. These are usually the patients that are on high flow either right before they get intubated or after they've come off the ventilator to kind of provide the most support. With our high flow nasal cannula, because that oxygen level is so high, we have to heat the oxygen, we have to humidify it, and we have to make sure that we look for any skin breakdown. This is still kind of in that nasal cannula area, so just watch out for skin breakdown in that area there. After that, we would move to mechanical ventilator intubation. That you'll go over in your complex care, but just know that is an oral airway, a tube that is placed into the mouth down into the lung area for breathing on your patient. Okay, so when we're using oxygen, we really need to make sure to understand oxygen safety. So depending on your device, depending on what you have here, oxygen is typically given through what's called the oxygen tank, or it could be through a concentrator machine like you see up in the right-hand corner, or in the walls at the hospital. Those are basically big giant tanks. Because oxygen is extremely it is flammable and supports combustion, it means that it does increase your risk for fire. So we want to educate our patient, especially if they have home oxygen or they're in the hospital, that we want to make sure that we never smoke around oxygen equipment. That doesn't mean we just take our oxygen mask off and hold it to the side while we puff our cigarette. It means literally no smoking, no fire, no open flame around oxygen. We want to make sure to educate the patient that they should use signage in their home or on their front door. Keep the oxygen away from heat sources like gas stoves, open flames, candles, heaters, those kinds of things. Never bring a spark around it, so no welding equipment, lighters, matches, anything like that. And make sure to also avoid other products that can increase fire risk. So that's going to be petroleum products. So remember how I said oxygen is very drying to the inside of the nose. Some nurses, you will see them, oh, I'll get you some Vaseline. We'll put some Vaseline in your nose to help, it not be dry. Petroleum-based products like Vaseline can increase the risk for fire. So we do not want to use petroleum products like Vaseline or oil-based chapsticks, lip balms, or lotions. We do, however, want to lubricate their nose with water-based lubricants, so like KY jelly or water-based lotions or moisturizers. Make sure to also educate the patient on storing the oxygen tank upright. It should be in the holder that you see there. This helps prevent that tank from falling and becoming damaged and possibly becoming a projectile item. We want to make sure to also prevent falls. So our patient can actually trip and fall on their oxygen tubing. So make sure that they watch out for that when they're ambulating and they're walking. I think that's it for oxygen therapy safety. Just make sure to always assess your patient, assess that they have the correct flow rate, the correct device, make sure that their oxygen is being checked, that their tanks are full, make sure that they're, you're checking lung sounds, checking breathing, checking pulse ox, all that good stuff as well. Okay, we're going to talk about asthma. So asthma, we kind of talked about, I think, is a chronic inflammatory disease. It is reversible, but it is a bronchoconstriction. It leads to airway inflammation and increased mucus production and kind of an airway hyperresponsiveness. So unlike COPD, the airway obstruction is usually reversible. So what we see is that the patient has a trigger that will trigger the asthma attack, which leads to airway inflammation, that bronchospasm, excessive mucus production, and then narrowed airway bronchioles or swelling in that airway, which can lead to air trapping and difficulty exhaling. So a patient becomes hypoxemic. Um, for our patients with asthma, three biggest problems are bronchospasms, the bronchial inflammation, and bronchial mucus. So that leads to that airflow obstruction. Now, our triggers just kind of depends on the patient. Some patients have an allergy or an asthma attack related to allergens like pollen, mold, pet dander. Some people are triggered by an irritant like perfume, cigarette smoke, air pollution. Some patients can have triggers from things like exercise, stress, medications. My son, when he was younger, would have asthma exacerbation after he got sick with a viral infection. So he would get like, the cold and then have an asthma exacerbation. For your clinical manifestations or your symptoms, your trigger words for asthma, this is going to be patients that have dyspnea, trouble breathing, they have wheezing, chest tightness, and usually a cough that is worse at night or early in the morning. When you look at your patient, these patients will have tachypnea or that rapid breathing. They are having accessory muscle use. So they have retractions. Those intercostal spaces are moving heavily. They might be using tripod positioning. I would like you guys to go look up videos for asthma exacerbation and look at accessory muscle use and retractions to kind of see what I'm talking about, how the intercostal spaces will actually retract and move in. For your patients, this is a life-threatening emergency because that airway is closing down. So what we will want to do is give medications that help open up the airway. So these would be your rescue medications, like your SABAs, your short-acting beta agonists. These are your medications like albuterol. They help with rapid bronchodilation. Now, these are your rescue inhalers, so the patients should not be using them for maintenance breathing. Your side effects or widely known problems with albuterol is that it causes the patient to become really jittery, nervous feeling. They have tremors and tachycardia. So just know your patient's heart rate is going to go up with albuterol. For your long-term medications, your LABAs, these are going to be things like inhaled corticosteroids like fluticasone or budesonide. These help to reduce that airway inflammation and help prevent attacks. So these are going to be your medications that you might take on a daily basis or a weekly basis to help prevent your asthma attacks. With these, because they are inhaled glucocorticoids or glucosteroids, remember to teach them to rinse their mouth after they use the inhaler because it can cause that oral candidiasis or thrush to occur. We can also do our LABAs, our long-acting beta agonists. These are going to be medications like your salmeterol or formoterol. These are for long-term bronchodilators. Now, your LABAs should not be used alone in asthma. Oftentimes, they are in conjunction with inhaled corticosteroids because labs alone can actually cause asthma complications to occur. We may use medications that are leukotriene receptor agonists like montelukast or Singulair. This can help reduce asthma symptoms and help reduce inflammation. But for the most part, you want to understand what SABAs are, LABAs are, and your glucosteroids and kind of how those all work together. Really understanding for those corticosteroids to rinse the mouth to prevent thrush. You also want to understand and educate your patient on how to use a metered dose inhaler. So that's their little inhaler that you see when people have asthma. So for our education, we want them to shake the inhaler, exhale completely, so blow out. They want to press the inhaler button and then take a deep breath in and inhale slowly. They then will hold their breath for 10 seconds. That allows that medication to kind of dissipate and flow into their lungs. Then they can exhale and then wait a minute between puffs. Now, sometimes we'll see that they utilize what's called a spacer. This is like a plastic device that goes over the inhaler, and it helps improve medication delivery because it helps with the patient not closing their mouth or breathing out or doing it incorrectly. So it helps kind of dissipate that medication at an appropriate rate. This is especially helpful for our kids. So we'll see spacers a lot in pediatrics. I'd like you guys to go look up a metered dose inhaler, look up a spacer, kind of look at what that looks like, and then make sure to understand how to educate your patient on how to do an inhaler for our metered dose inhaler. For your acute exacerbation of asthma or asthma attack, please remember we've got to get that oral airway open up, that broncho airway, or the not the good grief, the bronchioles and that bronchus, we got to open that up. So get that airway open. Then we can give some oxygen. We can give steroids to keep it open. Oftentimes that medication of choice is albuterol, but remember it does come with those side effects of tachycardia and jitteriness and shakiness. We can have a life-threatening emergency. It's called status asthmaticus. This is an asthma attack that does not respond to bronchodilator therapy. And oftentimes what we see is this patient has increased confusion, cyanosis, their oxygen is not coming back, they have increasing CO2 levels, and the patient just kind of gets really exhausted. For this patient, intubation and potential mechanical ventilation does occur. I think that's it for asthma. I think that's all I wanted to talk about on this one. Okay, here are some medications for your asthma treatment. These are going to be your SABA or your short-acting inhalers. This kind of talks about the onset of action, duration, kind of gives you a couple little names for the albuterol inhalers. Or not albuterol, your SABA inhalers, albuterol being one of them. Albuterol is your most common one as well. These help open up the airway. Here is a table for your long-acting breathing treatments or MDIs. These are going to be for your patients to take long-term every day to help decrease the risk for an asthma exacerbation. All right, so cystic fibrosis is going to be another respiratory disorder. Cystic fibrosis is actually a genetic disorder that can affect the exocrine glands of the body that helps or causes a production of mucus in the patient's respiratory system. So this patient will have abnormally thick, sticky mucus. This mucus will actually block the airway. It can also block like the ducts of the body system, like the pancreatic duct, the sweat glands, the reproductive tract. and can actually cause like blockages and like pancreatic failure and things like that. For our purposes in this lecture, these patients are going to have abnormal airway clearance in their respiratory system. So they're going to have airway obstruction. They oftentimes will have chronic infections because that super excessively sticky, thick mucus actually will trap infectious material and kind of not really be able to be cleared out of the body. And so they will have chronic infections. They'll have increased inflammation, and then they can have progressive lung damage. For this patient, these are genetic, so we will see these a lot, see these patients a lot, children, so they'll come in with cystic fibrosis, they're born this way, and so we'll see this even in our peds patients. For our signs and symptoms, our cues, we are going to have a chronic cough, super thick sputum, frequent lung infections, dyspnea, crackles, wheezing, and then clubbing of the fingers. These patients may also have other signs and symptoms related to different systems. So our GI system, they can have greasy, foul-smelling stools. This is called statorrhea. They can have poor weight gain, vitamin deficiencies. Other things to note, so NCLEX trigger words would be salty skin. So these patients will actually have salty tasting skin, like when their parents give their babies a kiss, they'll go, oh, it's like salty on their skin. This is because the patients lose an excessive amount of sodium and chloride out of their sweat as well. For these patients, we will kind of do some screening, do a sweat chloride test. This looks at the amount of chloride in the sweat, and we'll diagnose them with cystic fibrosis. For our medical treatment, main things are that we do airway clearance therapy. So this is chest physiotherapy. This is where the patient, we will take our hands and cup on their, kind of in a cupping shape of our hands, and then we'll kind of pat on their back, on their chest, and have them roll in different positions. We can also use a chest physiotherapy belt. It's like this belt that they put around their chest, and it like shakes them vigorously. That helps break up the mucus, and then with position changing, certain positions, like they'll have them roll on the right side, then their left, then their sit up and all this stuff, that will actually help to bring that broken up mucus and move it out of the lungs into the airway down into the GI tract and kind of move it through the body so it can be expelled. This just, again, helps to loosen that thick mucus up. We can use inhaled medications like albuterol to help with bronchodilating and to open that airway. This is usually given right before we do our physiotherapy or, the airway clearance therapy. We can use mucolytics. This helps to break down mucus and helps thin the mucus so that it's easier to cough up. We can also use hydration, saline. This helps to thin secretions up. Antibiotics if there is any type of respiratory infection as well. So for these patients, nutrition is required because they need a high calorie, high protein diet because they have increased energy needs. They do have a high risk for malabsorption, so they would need a high fat diet and high vitamin supplements, so A, D, E, and K. Besides the chest physiotherapy, make sure you listen to breath sounds, check oxygen saturation, look at respiratory efforts, prevent infection, to avoid respiratory illness. I think that's about it. Yeah, I think that's about it for these patients. Here's just a little picture for cystic fibrosis. This has your treatments, your meds, your salty taste on skin, and then some of your symptoms for cystic fibrosis. And this brings us to the end of the lecture. So the rest of the slides here are just some practice questions. Please let me know if you have any questions on your respiratory lecture, but make sure to study everything here and correlate it to your ATI learning.